So this is what I was fighting for years and years. I would treat these extremely complicated patients that, we had a reputation for being able to treat the sickest patients. So if you had multiple my program, the team I built at the psych hospital.
Where was it?
In Pasadena, Los Encinas Hospital.
Okay.
And if you had seizure disorder and you were, coming off drugs and you had tuberculosis and you had cancer, whatever it was, and you were psychotic, we could handle it, no problem. But I would get the insurances would call day one to go get the patient out. Day one, the patient needs, conservatively, 3 months of care, at least 2 weeks in an intensive environment to get them stabilized, get them out. And you'd end up talking to a clerk or somebody who had some clinical background on the other end going, no, doesn't meet our criteria, get them out of there. And the game was, then the patient would call and complain to the insurance company. And they go, oh, Mrs. Smith, we don't, there's just Dr. Pinsky has to tell us what it is you need. And of course, we're happy to cover it. They don't tell the patient is they set their own criteria. The criteria are very arbitrary and have no relationship really with clinical reality. And of course, my patient needed lots of care, multi-system issue, doesn't meet their criteria, psychiatric criteria. If I would use medical jargon, I could scare the shit out of them, and they'd keep them in the hospital, even for minor conditions. They go, I hear a holosystolic murmur in the, at the apex, and I think they probably have a choroid tenure and maybe some ischemia. Keep them in the hospital 4 more days. Fine. But if I said they're coming off heroin, they're in the middle of withdrawal, they're craving, they've never had a sober day in their life, they're a little bit, there might be a depressive disorder there, they're a little bit suicidal, but not actively, they'd go, yeah. Send him home.
So what's the answer?
The answer is, I've been through 3 waves of so-called parity, which is what you were saying, that there's really not parity, which is exactly correct. It needs to, it's some way, and I don't know how you prevent the abuses of this, but in some fashion, the parity has to be, the doctor is of the opinion that the patient needs 3 more days in the hospital, whether it is medical or psychiatric. And I work on both sides of it. On the medical side and the surgical side, they don't really argue with us. On the psych side, crush everything.
Just because it's easy. There was a documentary done not too long ago. We were just talking about this last night.
Maya?
Do you know that story?
No.
Is that the documentary? Taking Care of Maya.
Taking Care of Maya. And she just won her case. Against the hospital for $220 million. But
Johns Hopkins.
Yeah. She came in with CRPS, I believe, diagnosed CRPS.
Which is, explain. What is CRPS?
You're using it. Tell me what CRPS. I don't
what
know.
is it?
Chronic something pain syndrome.
Oh, chronic regional pain syndrome.
Yeah.
Okay.
Whatever. She was diagnosed by a specialist. They couldn't afford the specialist anymore. They ended up going to the hospital. The hospital didn't know how to help her, and they ended up thinking that it was Munchausen's by proxy, and they separated her from her parents. Then they said that it was fictitious disease.
Right, which is CRPS. Sometimes they throw it in there, yeah.
Yeah, so then they said she doesn't actually have it.
And the whole while, I'm sure they were spooling her up on opiates, right?
Well, and they went back and they looked, and the hospital was actually, even though they said it wasn't CRPS, they were charging the insurance companies for treatment of CRPS.
Yeah, it's a mess.
Yeah.
It's a mess.
And that was the only way they were able to make the money.
So it's
I don't know if that has anything to do with what you're.
Well, what I'm saying is that it's a two-way street. The medical community or hospitals or pharmaceuticals want to overcharge and make money. It's for profit. And the insurance company wants to make money by charging you for this coverage. But I saw a documentary once where they get a stipend for being able, when a claim comes in, for finding a reason not to.
Yeah, it's called a risk pool. They hang out as much as they can and give you as little access to as much as they can, and you take a certain percentage right off the top and put it in a bond fund. So it's a mess, and I've been fighting my entire career to try to. First of all, they've adulterated the physician-patient relationship. They've superimposed a bunch of stuff on top of it.
What does that mean?
They've made it impossible for us to care for patients. I think I just pulled my headphones out or something.
Did you?
There we go.
Oh, you're good.
And I'm really at the point where I'm thinking we have to run up the white flag. We lost as doctors. We have no control over the care of our patients. We really don't. We have very little control. And what control we had, now it turns out 70% of us are employees. So they're listening to whatever their employer tells them to do. That is not how medicine is practiced well. Somehow we have to find a way to, so your most efficient unit is a properly trained caring physician and a informed, motivated patient. That's it. Doesn't get better than that. That's your most effective unit. You do anything to that, you're screwing it up. You're making it worse. They've completely adulterated the doctor side with us working for insurance companies and hospitals, and it's so ridiculous. And pharmaceutical companies, as you mentioned.
So that a doctor working for a hospital is not motivated by treating the patient with the best possible care?
Look, he or she is for sure, but look what happened with COVID. From on high, they handed down, I make them go home, send them home, tell them to come back when their PO2 is 80. That was astonishing to me.